private healthcare. I want to start also with the same question with you, Dr. Shwari. You're from KZN. The gap between public and private healthcare, the NHI. Where are we with the NHI firstly?
NHI, I believe, is like any other insurance. And for any insurance to succeed, you have to have healthy people or to make money. I mean, it's private or NHI as a public sector initiative. So I think there has to be a connect somewhere for it to make it successful.
Okay. If anybody else wants to pitch in, you know, pitch in. We're just having a discussion over here, talking about, and the topic of this is specifically about South African healthcare, ladies and gentlemen. It's alive with possibilities, and there are also dire challenges. Now, I want to talk about those challenges because if we start off with the challenges, we can look at where we are, to untangle the situation and get the situation better. So, who wants to talk about where we are at the moment? Let's start with you, Nene. Where are we at the moment? From your perspective, representing a company called Accenture, where do you see the South African healthcare industry being at the moment?
I think we've made strides, Aki, in terms of making sure that we look out for the poor. NHI is very close to my heart because it's actually encompassing in terms of ensuring that everyone has access to healthcare.
Yes.
And I think where we are now, we are moving towards the right direction, but like you say, there are always challenges. And I think technology plays a very critical role in terms of ensuring that it enables whatever visions that we have to make sure that they are realized. So technology plays a very important role, and I think we really are making good progress in terms of NHI moving forward.
Dr. Mulder, where do you see the situation? Where are we in the country at the moment when it comes to healthcare in South Africa? Are we moving in the right direction? Are you happy where we are at the moment? What are the challenges in your eyes?
So I'm coming from the perspective of a research organisation. So we play very much, higher up the value chain rather than down on the healthcare side. But certainly the research done by the Medical Research Council shows that we still have a massive burden of disease in this country. We have a quadruple burden of disease, and although the solutions are out there, I think to me the biggest issue is getting them out to where they're needed most. I don't think we have a lack of solutions, technologies, new drugs, new diagnostics. Obviously we haven't solved every problem yet, but there is this huge gap still, and I think a lot of effort needs to go into implementation, to integration, to cooperation, to make sure that we get these technologies out there to where they're needed most.
And I think it's also about opening up the ecosystem, to allow people to come in, entrepreneurs to come in, to find different solutions. And this is where Siraj Adams comes in. Just tell us a little bit about yourself and your company and where you fit into the healthcare industry.
So I think from our side, EASA Health is a community-based last mile delivery solution. And I think inclusive innovation is going to be key to the impact of NHI. At the end of the day, you've got your urban areas, suburbs. They are generally serviced well with regards to private services. But in terms of the lower income areas and townships, that is where a lot of corporate companies struggle to have an impact with regards to healthcare. And a company like EASA Health started out as a little bicycle delivery company, delivering chronic medication, and we've evolved into a digital health solution company with national logistics capabilities. And I think what's important is that it was from the inside out, where we have included people from the community in our design process. I think earlier the UX process was described, in terms of what is it that people feel are challenges. If we talk to the Western Cape, for example, as one of our pilot provinces, obviously decentralizing stable patients is well published within the Western Cape. They've rolled out adherence clubs, etc. But there's still the part where, what if patients can't get to the clubs? How do we get care to them? And I think the empowerment of community health workers, or even lay people with digital technology solutions, to be able to say that they're not a doctor, but they're empowered with clinical decision support tools that will make their decisions easier for them, is the way of the future, where you want to decentralize care into the community.
interesting stuff. Now, MEC, I know that the deregulation of the industry is a big challenge for everyone sitting over here. When you hear regulation in any industry, whether it's the cell phone industry, whether it's in finance, for example, it's just a massive headache. And sometimes it's a hurdle, it's a stumbling block. Where are we with regulating, this next phase of healthcare globally? Because it's no doubt going to change and impact, and it's certainly the way to go. But how do we go about regulating health tech in South Africa?
As part of the NHI document, actually, I think it's the first time that you can see the health tech being mentioned compared to the other previous legislation. If you look for example, if you look at the other draft of the NHI, starting from as far as 2009, in terms of the National Health Act, it's not much covered there. And if you look at the in the previous National Health Plan, it was covered there. So in terms of the regulation, I think probably one has to wait until that they've put together the streams for the NHI implementation, which is probably they could have a commission within them. I'm talking about at the national level. Because, as I indicated earlier, when they had the e-health strategy, there was supposed to have been provision, but they, for the national, so they've been so slow up to where it has expired. And in terms of the standards related to the CETA, we find that it doesn't cover a much part of it. But however, you cannot wait now for the national, because as I indicated earlier, that it's a concurrent competencies between the national and the province.
Right.
And within the provinces, they never repealed the National Health Act of 1977. I'm talking now about in terms of the legal matters. Therefore, the provinces can still be able to piggyback on the 1977 because it gives them more powers, because of the Constitution Schedule 4, that they can also stand on their own. So whilst we've got National Health Act, that doesn't make much of the provision of the technology, but the old 1977 Act, it does make a provision so that the provinces don't have to wait. So that's why with the Western Cape we've got the IT e-vision strategy, which is now we are implementing. But again, you have to also to drop the shoulder in regard to if national wants to piggyback on some of what we do, at least we can have a listening, because at the end, those indicators, they feed to the whole system that goes to the international system.
Now, Dr. Shwari, in KZN, you've been running this system at the KZN Department of Health, where you've really embraced digital health with the digital health records and all these kind of things, and you've been doing some impressive work over the last few years. How much of an issue has been the regulation in digitizing the process you're talking about?
We have done a lot of work, but we haven't progressed at the pace we wanted. Out of 80 hospitals, only about 5 of them have got some kind of electronic health records in hospital.
Why is that? How is it in today's age that there's such slow progress being
The
made?
main challenge is the infrastructure, the IT infrastructure. The connectivity isn't still an issue. All the hospitals are on the government network, the CETA network, but it's not good enough. We need more. On an average, you have about 2 megabits per second in a hospital situation, and it's not good enough. That is what is required at a clinic.
Say 2 megabits per second.
Yeah, that's what we have. But what is required is much. And once we have that, I'm sure we'll be able to extend it.
So where's the problem? Is it the commitment from government?
I think the comms, the communications companies have to come down with the pricing. I think that is where it makes it difficult for us to implement. It's very expensive to actually have the bandwidth what we require at this stage.
Okay. Now, when I was talking about regulation, I could just hear Nana agreeing. It's a big problem in the industry, is it not? To try and regulate this. And I get the sense that everyone's trying to do it their way, but we're not taking necessarily one blueprint and replicating it across the different provinces.
Yes, actually, I agree, and I think already in the country there are conversations around the service provider, the communication service providers coming to the party, and I think you've challenged them somehow to say they must come to the party and help these kind of initiatives. We can't be now complaining with the fact that there isn't enough bandwidth, and yet you have service providers that should be coming to the party and helping us moving forward.
So that it's interesting that in today's age, where we have got fiber and we've got incredible connectivity in this country, that we're still having a discussion of the connectivity being an issue as the enabler. I mean, it's quite disgraceful when you look at the country that we're living in, that we're having this conversation as the last mile. And this is a critical aspect of people's lives. What kind of issues are you facing at the SA Medical Research Council? I know you said you're like one step up, but it's such a critical role that you play in this puzzle of putting these pieces together. At the end of the day, probably the most regulatory hurdles are faced by yourselves, right? I would say in the bigger picture of healthcare.
Yes, so I'm going to talk specifically about digital health. I wouldn't say the regulations are a huge problem for us. I think, in fact, our biggest challenge perhaps is procurement by the Department of Health. So the MRC supports a lot of health tech innovation, and a number of the projects we supported to date have been in the new apps, so the digital health space. And what we found is that we're using public funds to develop these apps. They're specifically around addressing health system issues, clinical guidelines, and so on. And yet when it comes to implementation, our first hurdle in our very first app was, well, if it's even though it was developed with public funds, the Department of Health has to go out and tender to be able to use the system. So they couldn't actually procure it from us. It cost very little money to develop. The first one we developed was, we facilitated and funded the development of it, was a mobile triage app. It was trialed in Cape Town, showed really, really good results. And when we took it to the provincial departments of health, they said, lovely, wonderful, great results, but we can't procure it without going through a long system. Just to change the subject slightly, while we're on the regulatory side, the National Health Normative Standards Framework for Interoperability in South Africa. Those guidelines came out, they were gazetted in April 2013, developed by the Maraka Institute at CSIR and some researchers from NMMU. And I think this will go a very long way towards ensuring interoperability. So if everybody, the idea, as I understand it, is that when we are looking to develop and implement new mobile solutions for the national, particularly the public Department of Health, then at least there's interoperability. If everybody uses the same framework and standards for data, for information, then we have some kind of interoperability and some kind of minimum standards that protect people's personal information, that ensures that we can integrate with the national systems.
Interesting. So certainly there are massive challenges, but I'm also getting the sense that as we move forward in the right direction, which everybody's moving forward to, we're embracing the challenges and we are adapting to what we need to do to change these things. But again, I'm actually flabbergasted by the connectivity issues that you spoke about. But let's take one step further. We're living in a society where populations are growing. You look at the population growth on our continent, it's going to be the fastest population growth globally. You look at how many people are coming to the urban areas and how overpopulated some urban areas are becoming. And I'm sure that hospital resources are coming under a tremendous amount of pressure. How can we use technology? And I'm not talking about the user experience and the digitization of the patient records, which are obviously going to make the whole process seamless, but moving forward to the next step of how technology is going to be the enabler for us to be able to provide better healthcare. And maybe start with you, MEC. When you look at the doctors, and we clearly don't have enough doctors, you look at how many people wait for weeks on end to see a specialist. It even happens in the UK that to see a specialist you could wait for months. How do we change the system? What do we need to do to make sure that technology addresses the shortage of these medical practitioners in the country?
Already in the Western Cape, with the issue of the e-vision, which inclusive of the e-discharge summary, where now the patients, because we also want to reduce the patients going for up and down, but at the same time to provide the whole information that is required within that electronic discharge summary, which is we have already implemented, especially around the pediatrics. The e-prescription and e-script already, where now it doesn't need a warm body in terms of to prescribe, especially around the pharmacy, and the script in terms of the repetition, because sometimes the services, they get overloaded, too much service pressure, yet the people are just coming for the repetition of the script. Won't even need to be seen in terms of the assessment, hence a part of the e-script. Same as with because you mentioned about the triage, with the EC tracker, emergency care, because what happens that emergency care areas, they are the point of entry within the hospital, but find that now the patient gets lost in the process where it would have been referred to X-ray and whatever, and then get lost. So now that identifier makes it to be able to be tracked, but also for the linking to the EMS, the paramedics, so that already they can inform through the EC tracker in terms of that there's a priority one patient coming in. Now the issue with the triage one that was mentioned was piloted in Khayelitsha, which is actually it was well received by the health facilities themselves. However, we do know when it comes to public health, you have to also look in terms of the efficiencies and all of those, in terms of the costs, and also the issues of the confidentiality, especially with the issue of the POPI now. We have to also look in terms of those. And the intellectual property, because although we try to do the electronic management of the stuff, but you still have to keep some of the hard copies, the digital hospital, patient records, all of those. But also you don't, it's supposed to, with technology, it's supposed to enhance the service delivery. It must not be an add-on. Like in some of the cases, it's where now the vendor or the provider has to make it a point that so many people need to be trained, which is the original amount now. It gets up more, it needs to be trained in terms of the implementation, which is the same people, the people from the facility, same people, and also cannot be trained by anyone, also by them, and also in terms of the intellectual property, that it becomes their own no matter what. So there's a problem of the transferability and all of those things. So we have to look in terms of those things.
Yeah. Now, Dr. Shwari, in KZN, for example, you've got some central hospitals, but you've also got some very remote rural areas, and healthcare, getting healthcare to those particular areas must be a big challenge when you look at the shortage of medical practitioners in the country. Where do you see the role of technology in the future to addressing these particular shortages?
Electronic health records, I believe, still pie in the sky from where we are. What we can do is start using technology to make life easier for our healthcare practitioners, especially in the rural areas. I'll give you an example. A patient gets seen at a clinic, gets sent to the next level for minor ailments. So we have to look at appropriate level of care. Just to give an example how much it costs for a patient to be seen at a clinic, it's about 200 rands. The same patient lands up at a community health center, it's almost double. The patient lands up at the district hospital, it's about 1,400 or 1,000.
How is that possible?
So it is because you have to look at the cost of what it costs for us to manage a patient at that particular level. So what can be done is to use technology to give advice in real time. You can have tele-video consultation between a clinic and a district hospital, where just referring a patient to the next level without actually discussing with a doctor or a specialist at the next level,
right.
We can actually make it happen. We did a pilot, successful one, between a rural hospital, which is about 275 kilometers away from Pietermaritzburg, and there is an ICU there where patients are being, the quality of service is being compromised. It's because the specialists, intensivists, they visit the rural hospital once in 2 weeks. So what we did was we gave them a computer on wheels with a web camera, 2 cameras, where now the specialists can be in Pietermaritzburg and still give advice in real time. So the patients are not being moved, especially because they're sick and very sick, they can't be moved, and we can actually give advice in real time. Instead of once in 2 weeks, now they're able to have a virtual consultation every day.
Now, we've had a discussion before. You originally are from India, and your background has also been experience over there. How does India compare to South Africa when it comes to healthcare and e-health? Are they making advances, or are they also struggling with the same challenges we are in this country?
The cost of bandwidth and connectivity is a bit cheaper there, so they have progressed quite a bit, especially in the rural areas.
But you see, this is why I asked you the question, because the correlation with cheaper data and data as an enabler, you know, it just it creates a huge impact and makes such a massive difference. Nene, from your point of view, for Accenture, you take a wider look even into the continent and in the country itself. Are we making good progress when it comes to the shortage of these medical practitioners? Obviously, as data being a big issue in this country, are we facing the same challenges as the rest of the continent?
Actually, we are, though we actually trying to make strides. What I wanted to also just emphasize is we need to also focus on prevention. We have community health workers, for instance, that are working in communities, and they do not necessarily have to be qualified doctors. So we can use the basics and empower them to be able to actually look out for, just do the basics in terms of the vital signs, etc.,
Yes.
etc. So within Accenture, for instance, we were looking at different technologies that are there where you can actually equip a community health worker to go out there with the basics in terms of your, blood pressure, in terms of any vital signs that you can actually do to a person, preventing that person from actually going and clogging the facility. Right. So you're already saying, you know what, this person doesn't necessarily have to go to the clinic, this is what I think they need type thing, but within a regulated framework. So there are those technologies that can actually help us not clogging the facilities, but also helping with the shortage of doctors at facilities.
Interesting. Yes, yes.
Just to add on, we did an initiative, we have an initiative in KZN where we have community care viewers that we are using now to collect information from the households. Without technology, what is happening is that they visit households, they fill up a form, the form gets to a central place with data capture, sit and capture, and there is a backlog of 6 to 8 months. No point in having information 6 to 8 months later. So what we said was, let us use a digital pen. I'm glad the previous presenters actually spoke about the digital pen. We give them a digital pen and a cell phone. They go from house to house, they walk, and they collect the information, and by the time they come out of the house, while they're sitting there, they tick and say send. It takes about 10 seconds for a 22-page form to go onto the web.
Oh, wow.
And the phase 2 of it is now we want to add point-of-care devices to it, to a backpack with point-of-care devices where we can check blood sugars, cholesterol, hemoglobin at the point of care.
So what you're saying is that if you get the basics right, you take a lot of pressure off the healthcare system. Yes. And education. And education is such an important aspect. But Siraj, I want you to comment on this as well, and I want you also to explain to us the role that entrepreneurs can play in healthcare, because you're an entrepreneur, you've come in with something different as well, but comment on what you want to do first before you comment on the entrepreneurship side.
Sure, I think also the government needs to be commended for certain aspects that it has adopted with regards to digital health, namely within the infectious diseases space. I mean, we have the largest HIV program, treatment program in the world. We've also rolled out very successful digital solutions that support the expansion of that program. MRC has been involved, there's Matuti Foundation at UCT, WITS research unit. So I think there's a huge, it was obviously a huge funding support with regards to HIV and communicable diseases. That's why there was this ability to upscale nurses to do NIM art and then provide them with a digital support tool to be able to calculate pediatric doses accurately without needing a pediatrician to verify as the child grows, can I change the doses. TB care as well, being able to determine what is the correct dosage for the preventative therapy, for the treatment component. So I think we have done well with regards to digital health. I do think there obviously needs to be more with regards to in terms of the prevention space. I think there's lots of room, especially in the vaccine space. I know we've rolled out the reminder platform for Road Health, which is the little book a mom has when they take a little daughter or kid for vaccinations, and they must stick the book and say that. But we still find lots of areas where outbreaks occur, and you'll have a diphtheria outbreak, and you'll find out that the kids didn't go for vaccinations because the mom forgot to take the child during the scheduling. So I think certain components we've done really well in, and I'll say within the HIV space, I think that we've done really well. In terms of entrepreneurship, if you look at the challenges of starting and making an impact, I think one of the biggest challenges is obviously finding a commercial value, because I think at the end of the day, without donor funding, which is where a lot of academic funding comes from, so your USA, your CDCs, they fund a lot of academic research. But within the medtech space, within the private sector space, it's very tough to be able to get the funding to go past concept phase into scalability, and then to be able to actually demonstrate outcomes. Because I think at the end of the day, be it government, be it private sector, all they want to see is uptake. So where are your numbers? So if you go to government and say you've got 300 people on a platform, they'll be like, oh, that's nothing. We're looking for hundreds of thousands. We're looking for large-scale impact. And I think there is opportunity. There's lots of medtech hubs in South Africa, be it in Cape Town, be it in Johannesburg or Durban. But I do think there's a huge opportunity, be it from the VC space or the angel investor space, to be able to drive the young doctors and pharmacists wanting to go into the entrepreneurship space, because they're the ones that experience the challenges in healthcare, and then they find solutions. But to get scalable and then ultimately adopted is really difficult.
I see one of the other problems as well when it comes to entrepreneurship is, and this is the biggest solution that faces this country, it's very simple, it's inequality, right? If we sort out inequality and we empower people, and we the gap between the haves and the have-nots, the gap between the people that are using public health versus private health, it's massive, right? You cannot compare the two, and yet we are failing in certain regards. We're making great progress in certain regards, but coming back to the entrepreneurship, I often find a lot of the products that entrepreneurs come up with might not necessarily be suited to public health because it's not affordable, for example. But yet we are coming up with some very innovative solutions, and further to the trip that we attended into San Francisco and Silicon Valley, you're looking at South African entrepreneurs doing the most amazing things and changing the world of medical technology. To sum up, I'm going to ask each of you to talk about, when you look at South African healthcare, what are those top 3 challenges that are on your radar? The top 3 things that keep you awake at night in your respective fields, and in a short sentence, what needs to be done, in your opinion, to change this and to accelerate the process, to improve the South African healthcare system and bring it to scale with a digital innovation that is taking around the world globally. Who wants to start off with that? Yours is easy, and
yes, it's easy.
Well, sell us the blueprint, please.
Money.
Money, eh?
Budget, yes. The first thing is a budget. With the economy that is growing so slow, that is very low, it impacts negatively on health. Not only it's about the poverty, because the linkages between the poverty and the people are unemployed, they become the burden to the state, but also in terms of healthy lifestyles, they don't have much choices.
Okay, so money is the number one.
Yes, money is number one, but also when you have that kind of a state, because I spend 6 billion on goods and services out of the 22 billion of my budget, which is part of it is medicine, which is very expensive with such an economy in terms of the export and all of those. So the issue of the budget, and noting that with health, unlike with education, where you might focus on the grade age 7 to probably age 19. From health is from the unborn to the oldest person, including the dead, because we don't even speaking about the forensic pathology yet. So the issue of the budget, and then secondly, the burden of disease. I think she has already mentioned it. We are still too much hospital-centric, more still acute. We haven't done much of closing the tap. We're still mopping the floor, giving the ARVs, fine, giving the diabetic treatment, chronic, whatever, but we don't focus much on the issue of the preventive and the community or individual themselves taking the responsibilities.
Right.
So for me, these are the two major things.
So you said your budget is 22 billion, right?
Yes, which is it's the biggest. Western Cape has got the biggest slice of budget compared to the other departments.
Just out of interest, let me see. Out of that 22 billion, how much goes to medication? More or less?
It's difficult to say, but it's out of the 6 billion, because half of the budget goes for the salaries anyway.
Yeah.
So it goes to the salaries, because I've got 31,000 staff members. Out of the 6 billion, that is for goods and services for supply chain, probably the medicines, there is about, I think, 2 billion out of that.
The reason I'm asking that is because it's one that we haven't touched on, is that the important role that pharmaceutical companies have to play in this over here with the cost of medication, etc. But thank you very much for those points. Siraj, your top 3 challenges, and where do you see the most immediate solutions that we can make to improve the systems?
So I think with regards to the budget, I think a challenge that all the provinces face is wastage. If you were to say what percentage of medicines that you've paid for already to procure from the pharma companies are sitting on the shelves, not being collected,
Really?
being returned as a percentage,
Sharp MEC.
but wastage is a real issue. I think all the MECs of health will confirm that discarded medicine is an issue, returned medication is an issue, and I think that's something that digital health can improve in terms of connecting patients to their treatment. Last mile delivery is ultimately where everybody wants to get to. They're all trying to decentralize as best as you can. But at the end of the day, the granny's looking after the children. She still can't go do a pickup at the pickup points. The wife has gone to work and she can't go pick up her family planning because at her work is an occupational health. So I think you're finding that a lot of money is being spent on drugs and procurement, and it's there. But getting it to the patients is always an issue, and eventually it does result in wastage. Secondly, I think access to young women is still an issue. I think if you're looking at health and school, there's a disconnect. It's still taboo to have family planning in high schools. Access to preventative ARVs such as PrEP is still taboo. And there's obviously the social impact of poverty. That's why we have blessings. They're taking advantage of the young women, buying them airtime and unfortunately forcing them to not use condoms, etc. That's why we have such a high incidence of HIV in young women. So I think by empowering young people to be able to access preventative therapy through digital solutions, because all of them are on Instagram.
Yes.
All of them are Facebooking and WhatsApping. So a phone is actually their personal solution to be able to access care, and I think that is potentially the future.
Wow, fascinating stuff. Dr. Mulder, what are your top 3 points? It doesn't have to be 3, it could be 2, that those kind of challenges that are immediately on your radar, and how do you see us fixing these issues?
Okay, so I have 2 that I'd like to talk about, and again, I'm deflecting slightly to not the
No, it's good to deflect because it's a wide system.
but more on the development side. I think the 2 that I would suggest is certainly from my experience, is one, when we embark on a journey of developing new solutions, and I do want to agree with what Siraj is saying, our best technologies that we've supported and have got out into the market come from doctors. They don't come from researchers who are sitting in academic laboratories. They come from doctors who are on the coalface, who identify the needs. And if we go back to the earlier talk on user experience, these are clinicians who know what the user needs, they know what the experience needs to be, so they're developing products that are relevant, that are needed. So, I think that's a very important point. I'm not saying that the researchers are not developing good technologies, they are, but sometimes you have to tweak them quite a lot to get them into a final product that's actually needed out there. But what I wanted to say was, as we embark on the journey of developing new technologies, I would like to really appeal to the Department of Health to walk with us from the beginning I think what doesn't work is that we develop a solution and then we go to the Department of Health and say, will you buy it from us? And will you implement it? I think if we develop it together, and we're starting to do that now with a new project, very exciting project that we're starting. We've got the Department of Health as one of our partners, and we're developing the solution together, we're raising the funding together, and we will actually implement together. And I think that really increases the relevance of your technology and obviously the chances of success. The second one I just want to mention is data. I think a better integration and management of data. We're about to spend 5 million rand on the rollout of the next antenatal survey for HIV. If the data systems out there were speaking to each other, that every clinic had all the records in place, you wouldn't have to go out and do a special survey. The information would be on hand because every patient who came in, everything would be recorded, could all go up to a central point. So I think you could do away with a lot of these huge, and even in HIV, much as there's a lot of improvement and a lot of systems in place, it's still fragmented, the data.
Yeah.
So when overseas people come and want to do modeling on HIV vaccine, they struggle a little bit to find all those data sources of what is our prevalence, what does our epidemic look like, rollout of ARVs and services around HIV.
And what about yourself, Dr. Ajib Ishwari? I'll give you one of yours. Connectivity. Right? That's number one.
Number one is still money.
Money, yes.
The allocation for e-health activities is non-existent.
You're kidding me.
Yeah, we don't have the support like how Western Cape has. The MEC is here to support the IT.
What's the budget for KZN?
For e-health?
For health?
For health, it's quite a bit. But nothing for e-health. Let us not get there. So what is percentage-wise is actually quite good. But for allocation for pardon?
I'm saying around about
35 billion.
37 billion.
So you've got 35 billion, but you've almost got zero allocation to e-health in 2017. Are you kidding me?
The thing is where it can help us going forward is the allocation of funding for e-health initiatives, so that we can actually. I'm not saying the litigation what we have, what we pay for medical litigation can be solved by e-health initiatives, but I'm sure most of it is related to that because we don't have documentation that we can. When we go to the court, we don't have enough. Folders are not there. Clinical information is not there. I'm sure we'll be able to make a dent in what we pay out for medical litigation.
So you're saying you pay a large chunk of your yearly allowance, your yearly budget goes to litigation?
It's not just our province, it's all over.
Yeah, it's all over.
It's all over, yeah.
Litigation?
Yeah.
Just
so
because we
what
don't
is
have the
required
right
is
records in
electronic
place.
health records, hospital information systems, document management, telemedicine, all that is going to help us.
Right, and data as well. Yeah. Okay, interesting stuff. Isn't this fascinating? You're looking at this from the outside, from Accenture's point of view, and it's fascinating to see the different challenges that are being faced in public health, in South African healthcare. What are your top three that you see?
Actually, I think technology has, most of the time, it's more of an afterthought. And I like what you said in terms of saying, let's build these technologies with the users.
Yes.
With the critical stakeholders and take them through a journey instead of sitting in our corners, developing a technology and giving it to the National Department of Health or any government department for that matter. So that's the first thing, and we should make sure that technology is integrated into business processes. It should be integrated into even the strategic vision, because most of the tech that has failed sometimes it's because there wasn't a proper integration into the vision in terms of management. Where do they want to see this technology? How is it enabling them to perform the way they want to perform? So for me, that's very important. And of course, we need to deploy more mature tech or applications and make sure that we support the different government departments moving forward.
What a fascinating discussion, ladies and gentlemen. It's incredible to think that in 2017, we are living in a society where there's an incredible disconnect, where there's shortage of money, where there is not enough data available, but yet we're making good progress. We are making progress. It does look positive. We are a country that is alive with possibilities, but the challenges are indeed dire that we face. And we shouldn't be facing these challenges. And the common denominator here, and this is what the IT News Africa Summit that we are here about is all about, is technology as an enabler. And isn't it amazing that when technology is deployed and applied, most of these issues that we've been talking about today will be solved instantly. This is the reality of the matter. And I think that if we all focus our attentions onto implementing those changes and using technology as an enabler, not only is it going to make a difference to the end user experience of the citizens, but we're also going to save quite a lot of money as well. Thank you very much. A round of applause to our panelists, ladies and gentlemen. Fascinating discussion.